Thank you, Chairperson, and good morning, friends. We've been speaking since morning about thyroid. First, we spoke about hypothyroid, then about hyperthyroid. But these are all slow kind of diseases, they continue in the OPD and then you just keep on going slow, slow, slow. So we would be excused if we felt a bit sleepy. But thyroid can present in many ways, in different ways. And sometimes it can present as an emergency. Now, when I was a student, we were taught by our teachers, he who knows syphilis knows medicine. And then I think when I became a consultant, then the dictum was, she who knows diabetes knows medicine. But listening to our previous speakers, I think the right statement would be, he or she who knows thyroid knows medicine, because there is so much to learn about thyroid. Bahrain in the past has been famous for its pearling industry. Bahraini pearls, I think the trade is not allowed anymore, but it is a connoisseur's delight. And I would like to thank our chairperson and our moderator as well for having got all these pearls together, for having created this beautiful necklace, this pearl necklace of endocrinology and thyroid. So let's wake up and let's talk about a few exceptional clinical presentations that we may encounter in practice. And this series of cases will just tell us that thyroid can come in many ways, in multiple ways. We need to keep our minds open, our ears and eyes open. So this 65-year-old gentleman who presented to the ICU came in with dyspnea. Now, when you have dyspnea, when you have respiratory symptoms, the automatic thought is it's a respiratory disease. It can be asthma, it can be COPD, it can be bronchiectasis. But if it's a 65-year-old male coming in with fresh onset dyspnea, chances of respiratory disease are less, chances of cardiac disease are more, so it might be heart failure. So this patient came in, there were no symptoms of hypothyroidism, but when the echo was done, if you just look at the ejection fraction, that was 60%, that was fine, so it's not heart failure either. But move ahead and then we saw pericardial fluid. So there was a massive pericardial effusion. And this can be one presentation of hypothyroidism. Again, when I was a student, we were taught in India the etiology of pericardial effusion. This was one of the easiest things to learn in medical college for us. The answer was number 1, tuberculosis, number 2, tuberculosis, and number 3, tuberculosis. Now that is almost extinct, and now the commonest cause is actually hypothyroidism. And this gentleman had a TSH of 150. So how do you manage? Of course, you will manage the hypothyroidism, but there are a few caveats. You have to go very slow, very carefully. In this particular patient, we started with 50 microgram, but many experts would even begin with 12.5 or 25 microgram and build up every week. So you have to go slow and steady, very slow, just like our hypothyroid and hyperthyroid speakers who are enjoying the talk. And you don't have to hurry, actually, to control or to bring the TSH down to normal. You have to worry about the symptoms. So our main aim is the breathlessness. That's what we want to improve. Now, this was a person who came to the ICU, and you may not encounter such patients frequently, but you do see ECGs every now and then. And if the ECG has a sinus bradycardia, a prolonged QT interval, low voltage, then these are surrogate markers of hypothyroidism. So we must investigate. Also, yesterday we spoke about heart failure, and we spoke about the fact that each and everyone who comes into our OPD is automatically stage A heart failure. This is true for the thyroid clinic as well. And when you're looking at TSH, when you're looking at the target TSH, how much to aim for? And then yesterday we spoke about the Goldilocks syndrome or the Goldilocks effect with hormones. This is true for TSH. It's true from a cardiac point of view. Because if the TSH is too much, the risk of heart failure will be more. And if the TSH is too little, again, the risk of heart failure is more. So it's good to keep the TSH normal, maybe between 0.45 and 4.5. Ejection fraction is a predictor for mortality in heart failure, but even more so is the T3 value. So if you have a person with low ejection fraction and a normal thyroid function, the prognosis will be better. But if this low ejection fraction is coupled with abnormal T3, low T3, then the prognosis worsens. So when you have patients with heart failure, with symptoms suggestive of heart failure, and the symptom is so easy in heart failure, it's just dyspnea, fatigue, that is it. then you have to monitor thyroid function. But do remember that you should treat slowly. This is true for patients with heart failure and also those with pericardial effusion and those with coronary artery disease. So start slow, build up start low and build up very slowly so that you don't worsen the patient as well. So this was one patient, pericardial effusion, and we've spoken about heart failure, we've spoken about sinus bradycardia, and we've also talked about the difference in our approach to a person with hypothyroid and coronary artery disease. Let's move on to the second patient now. Again, a gentleman, 58-year-old man who presented with epigastric pain, pain in the stomach region. He had a cancer of the esophagus, and he did give a past history of having had Graves' disease in the past. He had been treated with radioactive iodine. His TRAB was not done, but certainly the TFT was done and he had been stable. So he had forgotten about his disease actually. A thyroid function was ordered prior to the surgery. That was also fine. And there was a hemiblock in the ECG, but the anesthetist kind of ignored that. The surgery was fine. The immediate post-op period was fine. But about 2 days later, the patient began to become drowsy. He had dyspnea, somnolence, he had to be intubated. Investigations were done again, and then suddenly the TSH was found to be 14. The TSH had risen. So usually the etiology of hypothyroidism in Bahrain in the Gulf is Hashimoto's thyroiditis. It is autoimmune. But this was post-radioactive iodine. In fact, Dr. Salman spoke about TRAB and the multiple ways it can be used. One other place for TRAB is to help you decide the type of therapy. If TRAB levels are high, then you will give antithyroid drugs, because if you immediately give the patient radioactive iodine, that can flare up. And if the patient has severe orbitopathy, Graves' ophthalmopathy, then also you will need a higher dose of steroids. Otherwise, it will worsen. And this is one of the other advantages of using TRAB. So in this particular patient, TSH was high, so we had a diagnosis. But see, in the previous one, we started low and we went up very slowly. Here it was an emergency, so we went fast. In this person, intravenous thyroxine was given. Intravenous thyroxine is not very easily available in India. And another option that we are using now is T3, oral T3, and we found it helpful. So in a developed country like Bahrain or the UK, you may not get such emergencies. But in India, it is quite common that maybe pre-op investigations were not done completely, or if they were done, suddenly you get a change. Here the investigation was done. And then when you need immediate addressal, then oral T3 is better than oral T4. It has a shorter half-life. It has a faster onset of action. And if as it is, the patient is in a Riles tube or is has an NG tube, you can give that oral T3 preparation through that. This particular patient got intravenous thyroxine, and he improved actually, so he came out. So this was a patient of mixed edema coma, post-op. Both our patients have been male so far, but usually these diseases are more common in women. And there is a gender gradient, a very strong gender bias in favor of women for autoimmune disease. So whether that is a sign of matter of pride, that is separate matter. So you have to be careful, and basic rules would be that you should screen everyone before an elective surgery. All are screened by our anesthesia colleagues, and a TSH should be done, especially if there are red flags in history or signs suggestive of thyroid disease, then a TSH must be done. Preoperative TSH I would recommend for almost all patients, because in case you miss this, then you can get in trouble during surgery or after surgery. Now, if you find in a preoperative workup hypothyroidism, if it's an urgency, then of course you go ahead. You initiate T4, you can give T3 also. Supposing you have no other facility at hand and you have to monitor your T3 values, you just keep on checking pulse. The moment you get into resting tachycardia, that means you've given enough. So you take a break and step back. So you begin the replacement, and of course, because it is urgent surgery, you have to go ahead, but be extra careful. If it is an elective surgery, it's a good idea to postpone. If it is subclinical hypothyroidism, and we have spoken about that this morning, various aspects of subclinical hypothyroidism, but we focus mostly on obstetrics. This is important for general medicine as well, for anesthesia, for surgery. If there is subclinical hypothyroidism, T3, T4 are normal, then there is no need to postpone. Many, many times we get patients referred to us asking for clearance. There is a joke in India as well. I do not know whether that is applicable to Bahrain. So anesthesia has a different name. So we have SPM, Social and Preventive Medicine. Anesthesia is known as Surgery Prevention Medicine. So if it's a government setup, they know how to prevent surgery. So one of the ways of preventing surgery is to say that there's a TSH of 5.3 and I will not treat until you get until you get a consult from Dr. Vyam in Bahrain or Dr. Salman in UK. So you tell them that T3, T4 are normal, we can go ahead. In simple words, you can tell the surgeon, what are you worried about? You're worried about bleeding disorders? Don't worry at all. You're worried about something happening with anesthesia? The pulse is normal, the ECG is normal, please go ahead. So you can go ahead with subclinical hypothyroid surgery. Let's come to our third case now. Let me talk about prevention. So since we said that anesthesia is surgery prevention medicine, there are different levels of prevention. In English, we are all aware of primordial prevention, primary prevention. That is, when there is no risk factor, still you want to prevent something. Secondary prevention is, primordial is you want to prevent for everybody. Primary is there is a risk factor, but the disease has not come in yet and you want to prevent. Secondary is there is a disease already, maybe diabetes, maybe thyroid. You want to prevent worsening of the disease. You want to prevent complications. So early diagnosis, early management. Tertiary prevention is there is a disease, there is a complication. Now you want to do the best possible. That's rehabilitation. So we are aware of all these. But there are two other levels of prevention. One is quaternary. Quaternary prevention is a concept that originated in Belgium. And what they say is you should avoid over-diagnosis, over-labeling, over-treatment. That is also a prevention. Do not unnecessarily treat everybody with subclinical hypothyroidism. Do not unnecessarily order thyroid antibodies for everyone. It is our duty as physicians to observe quaternary prevention. The fifth level is quinary prevention, and that is becoming more and more important in today's world. Quinary prevention concept has actually originated from India. And what quinary prevention says is that you should prevent misinformation and you should promote the right information. So that is what we are doing here in BDR. This is what we should do when we go back and speak with our colleagues in different specialties. So promoting the right information and also ensuring that that unnecessary therapy is not given. That is the crux, or that is our theme for this case, the third case. So this was a 72-year-old gentleman. I think I'll be accused of gender bias. 3 males in a thyroid series. Admitted to ICU with urosepsis, and he was sick. He was in septic shock. And when the thyroid functions were done, T3 was low, T4 was low, and TSH was also low. So everything is low. Immediately, the endocrine student will think central hypothyroidism. Something is wrong with the pituitary. The pituitary is abnormal, T3 is low. That is why TSH is low. That is why T3 and T4 are also low. Someone like me, when I was in medicine, my first diagnosis will be the lab is wrong. The lab people do not know how to do the assay. But neither of these is right. Actually, this patient had something called, earlier it was known as euthyroid sick syndrome, ESS. Now it is known as non-thyroidal illness. This is quite common in the ICU. It is common after severe illness. And we have seen a marked increase in these kind of values after COVID, about 2 years ago. So here, basically what happens is, let me try to explain, keeping science apart, keeping these slides apart. The patient is sick. The body wants to survive. So the body begins focusing all its energy on survival. So the first thing that the body says is, let me get rid of some T3. I do not need T3, so I will spend less energy, less protein, trying to synthesize the T3. Patient doesn't recover. So then the body says, let me try some more and let me stop producing T4 as well. So T4 levels also come down. And because the body is so focused on survival, the pituitary and the hypothalamus, they do not get time, or they're not given the liberty, the opportunity, the luxury of responding to this. So TSH remains low in spite of T3 and T4 being low. That is how it happens. So if you have a patient who is admitted, first of all, T3 will fall, then T4, and TSH is going to remain normal or on the lower side of normal throughout. This is non-thyroidal illness, and because it is non-thyroidal illness, we do not need to treat with thyroxine. So you should be able to differentiate between central hypothyroidism and non-thyroidal illness. There is something known as low T3 syndrome as well, where T4 does not get converted to T3, and this can also create problems sometimes in reading the assays. The fourth patient, again a male, and I'm mindful of time. Now, because we should balance between hypo and hyperthyroidism, so our first two cases were hypothyroid. The third one was non-thyroid, even though the TFT is abnormal. And the fourth is actually something which even I do not see very frequently now, though I used to see it a lot 25 years ago. That is a thyroid storm or Graves' disease. Here we had a sick patient admitted after a CABG. TSH was very low, T4 was very high. And this was thyrotoxicosis. It was thyroiditis. And sometimes you can get thyroid storm, though I would admit that I have not seen a thyroid storm patient for the past 2 decades now. Mortality is high. Thyroiditis is common where I practice. Thyroiditis, that's itis, usually it will be viral. It can be idiopathic. In COVID, we saw a lot of thyroiditis. We continue to see. And again, when we were speaking of quinary prevention, which means you go back and speak with your colleagues, another reason for thyroiditis in our colleagues who use C-arm in orthopedics, or those who do a lot of angiographies, or those in radiology, that is that they forget to wear their neck shield, and then they get exposed to all the radiation. So every now and then we have our colleagues from orthopedics and from cardiology coming in with thyroiditis. So this is something we should be aware of. It is a public health issue. Thyroid storm also, there are scales like Dr. Salman showed for the relapse of Graves' disease. And one thing you must do when you are even contemplating the diagnosis of thyroid storm is to avoid aspirin. You can give other drugs, but avoid aspirin. If it is a hyperthyroid patient and you have to plan surgery, again, if the T3 and T4 are normal, you go ahead with elective surgery. But if T3 and T4 are high, then you speak with the anesthetist, with the surgeon, see how urgent that surgery is. If required, then you might have to give beta blocker coverage if the surgery is emergent. These are the 4 cases I had planned for today, but yesterday while speaking with some of you, we realized that T3, though is not available in Bahrain, it is available in neighboring countries, and there is a lot of discussion about when to use T3 and when not to use. So this is the way I remember it. Just 2 slides more. T3 should not be used as routine therapy in hypothyroidism. That is a very clear-cut statement. If at all you use T3, how will you use it? Either you will use it for initiation of therapy, or for intensification of therapy, or interchange of therapy. These are 3 things. Initiation should ideally be done with T4, with thyroxine. Interchange in diabetes or in any febrile illness, if you're talking of antibiotics, or in thyroid. Interchange is done if there is a safety or tolerability issue. My patient is not tolerating metformin. Pioglitazone or sulfonylureas are not safe for my patient. Then I will interchange. I will shift to another drug, like maybe to insulin. So that is interchange. Intensification is, there is an efficacy issue. Metformin is not sufficient. DPP-4 inhibitors are not sufficient. There is no safety or tolerability issue. They're just not sufficient. So I have to add. That is intensification. So coming back to T4 and T3, usually T3 will be used in an intensification process. It is highly unlikely that you would have to interchange T4 to T3. It is highly unlikely. And also it is highly unlikely that you would have to initiate with T3. So do remember that there will be a minuscule number of patients who will require it. But who are the ones that will need T3? So this simple way of remembering, again, pearls of S. If your patient has severe or symptomatic hypothyroidism, if the patient has secondary hypothyroidism, like that is central hypothyroidism, another word for that, if swift redressal is required, like in my cases also I showed, if somebody has come in with mixed edema coma, somebody needs an emergency surgery, and you have to get the T3, T4 under control, you need to be fast, then T3 is a much faster drug than T4. If there is, like we said, for sufficiency, if adequate doses of T4 have been given, 100, 200, 250 microgram, you've ruled out everything. One other thing to rule out apart from lack of compliance is celiac disease. If you've ruled all that out and you've not got sufficient control with T4, then you will add T3. If the patient is not satisfied, patient is biochemically euthyroid, but is still symptomatic. Again, there can be many reasons for that. It can be anemia, like we discussed yesterday. But it can be something known as tissue hypothyroidism. So what is tissue hypothyroidism? Just like yesterday we spoke about functional iron deficiency because of hepcidin, there can be a functional deficiency. So there is enough of T3, T4 that works like a key, but maybe the receptors are not working. So if there is lack of satisfaction, your patient is unhappy, then you can consider adding a small dose of T3. Like we said, swift redressal that associates with surgery if swift pre-anesthetic clearance is required. And then biochemical indications. Suspected deiodinase deficiency. T3 is very low, T4 is reasonable. It means T4 is not getting converted to T3. We can think of doing T3, T4 ratios, but they are usually used to differential diagnose Graves' disease from acute thyroiditis. They are not used in this setting, but you should be aware that you can think of that as well. And then surrogate markers of hypothyroid. So like we said, tissue hypothyroidism, your patient is unhappy. There are symptoms, that is tissue hypothyroidism. There is no single test to catch hold of that tissue hypothyroidism. It's a very slippery eel to catch. You can't catch it, a very slippery fish to catch. But some surrogate markers would be raised liver enzymes, high cholesterol. And like we said, we were speaking of T3 because I thought it was important. There will not be many patients who will require it, so do not begin prescribing to everybody in your OPD. And do remember these contraindications and caveats and concerns. Do avoid in women who are planning pregnancy. Avoid in patients like our case number 1, those with pericardial effusion, arrhythmia, or coronary artery disease, at least unstable coronary artery disease. Avoid at all costs in patients with osteoporosis. And do be aware that there is a potential of abuse for short-term weight loss. Young boys and girls will come to you. They will say, I want to take this drug, or I am already taking this drug. And it helps me a lot, my weight is coming down. So then we speak to them about a concept of physics, speed and velocity. Speed means you are running fast. Okay, young man, you are losing weight. But velocity means you are running fast in a particular direction. So you may have very fast speed right now, but all this weight is going to come back along with osteoporosis and arrhythmia. And if Newton's law said there is an equal and opposite reaction to every action, then Dr. Vyam Hussein's law says there is an opposite but more than equal reaction to weight loss. If you lose weight suddenly, you will gain it back with 10 kg extra. So this is how you counsel the younger boys and girls. And of course, avoid using it in sick euthyroid syndrome as well, unless you are very sure that you are dealing with central hypothyroid. So these were some other pearls that we wish to share, and I'd like to thank you for being with us this morning.